Motherfuckers! Today we meet here communing to talk about the stellate ganglion, a portion of the nervous system located in the neck, which has direct implications for PTSD treatment and bountiful indirect uses for downstream PTSD symptoms like painful, life crippling somatizations. This is something I had not heard of before getting the tip off from our community fucker, the Planet Streamer, or you may know her as Somber Mercy by her professional artist name. So today we're jumping into some quite cutting edge research. And I have to give them a giant thank you for the brain-busting share. But don't take our word for it. We're gonna let the authors of this research describe it. This is the summary version of the episode. If you are looking for the long, excerpt-filled version, please check Patreon. Today, let's hear first from the paper Stellate Ganglion Block for Post-Traumatic Stress Disorder, a comprehensive review of evidence, technique considerations, and symptom outcomes in military and non-military patients. It's by Bielawek, Melvin, Sandeep Ram, and Eniscu. This was published in Current Psychiatry Reports in 2026. Told you. Cutting edge. So I think all of us have a sense that things have been progressing in the world of therapy and PTSD. Thanks to the medical community finally acknowledging post-traumatic stress disorder rather than shell shock or malingering or personal weakness. Targeted therapies have been rapidly improving. We no longer recommend generalized SSRIs or one-size-fits-all interventions, but instead use multidisciplinary treatments to tackle the myriad causes and symptoms of the disorder. One of the most modern treatments is the stellate ganglion block. Stellate ganglion blocks, SGBs, involve injecting anesthetic between cervical vertebrae in your neck, to stunt the activity of the stellate ganglion. The stellate ganglion itself refers to the fusion of the cervical and thoracic ganglions. This area contains the nerve interchange between the brain, upper limbs, and head, and it's known to hold a central role in sympathetic nervous system activation. That's your fight or flight response. So the wild part is that the stellate ganglion block is foreign. It's news to most of us, but it's been used since the 1940s to treat depression. In the 1990s, it was first utilized for PTSD in conjunction with medication and traditional therapy. In the 2000s, it finally became a subject of scientific research, exploring these anecdotal and clinical connections. So, although the stellate ganglion block procedure has been used for PTSD, pain, heart arrhythmias, and other nervous system aberrations, the mechanisms by which it is effective are currently, say it with me, unknown to medical science. One theory is that the block reduces nerve growth factor and nerve growth, which can then decrease neurotransmitters and nervous system activity. The authors tell us this block has been utilized in pain conditions in the head, upper limbs, refractory angina, and cardiac arrhythmias that occur as a byproduct of abnormal connections between the sympathetic and sensory nervous systems. The precise mechanism of the block has been a topic of investigation. However, newer theories suggest that the block may reduce the amount of nerve growth factor and neurite overgrowth, causing a decrease in norepinephrine and sympathetic activity. So, to better understand these connections, the authors conducted a review of the prior publications on the stellate ganglion block. Reminder, all of which have been published in only the 2000s in order to seek answers. And they found Well, the majority of previously published research on stellate ganglion blocks confirm that it's an effective treatment for PTSD, including in non-military applications. We'll talk about why they added that in just one moment. The largest study on the topic reports that over 80% of patients experienced, quote, significant improvement of symptoms following the procedure. Other research has indicated anywhere from 50 to 70 to 96% efficacy across patients in reference to clinically decreasing their scores on the PTSD checklist of symptoms. These figures are quite staggering. It seems that not all symptoms are significantly improved as much as others, though. Symptoms like nervous system hyperarousal, reactivity, and avoidance are the most affected symptoms of the stellate ganglion block. Declines in emotional behaviors like numbing, having outbursts, and being irritable are included in these positive, significant changes. Traumatic re experiencing, however, is not shown to be greatly improved. This means the stellate ganglion block is not necessarily appropriate for treating nightmares, flashbacks, and intrusive memories, but it could help with the resulting emotional and autonomic upsets, better assisting the individual in re regulating themselves rather than spiraling. And when it comes to anxiety and depression, the comorbid horsemen of PTSD, unfortunately, the results are all over the board in the existing literature. Some research found meaningful improvement for at least a month, but one study showed no improvement in depression, anxiety, or pain, and two additional cases suggested that a left-sided stellate ganglion block increased anxiety symptoms, which was improved after a subsequent right side block. These results, of course, are controversial and may indicate depression and anxiety can't be knocked out by local anesthesia. But perhaps the most exciting news is the SGB doesn't appear to diminish cognitive performance to influence the improvements that it consistently causes. In other words, despite improvements in arousal, emotionality, and reactivity, memory, attentional capacity, and reaction time aren't stunted overall, which is a welcome improvement compared to some other treatments that may improve PTSD symptomology, but at the expense of broader brain functioning. But another thing to note, in general, the greater the PTSD severity, the greater the improvement caused by the stellate ganglion block. And on a surface level, this can be explained. If you have a greater challenge, you have greater improvement possibilities. So it may not be that the stellate ganglion block is ineffective for mild to moderate cases, just that it will be relatively stronger when people are having greater dysfunction, disorder, and life intrusion from their PTSD symptoms. Furthermore, the stellate ganglion block is effective across military and civilian applications. The procedure has been studied most widely in combat and military trauma, but studies including civilians have also reflected meaningful improvements in symptomology in both men and women. So here, the caveat is that military members indicated greater improvements in their PTSD symptoms compared to civilians, which one might hypothesize is due to nervous system dominant symptoms that come with intense war experiences. Those are my words, not their deductions. However, they do say these studies support that the stellate ganglion block is effective for both genders in both military and non-military populations, irrespective of trauma type. And the block is effective for some duration of time. The results of the stellate ganglion block have been validated between 1 day and 6 months. In one study, demonstrating that nearly 3/4 of patients had significant symptom improvement persisting beyond 3 or 6 months without correlation to prior PTSD symptom severity. It appears that the results of the block are not fleeting. And these results might be even more greatly improved by the application of adjunct therapies, meaning in most research studies, the authors noted that the participants had previously failed to find improvement through standard therapy approaches or otherwise received care that did not assist them. However, significant improvements post stellate ganglion block were seen in patients without previous therapy attempts as well. Positive results were seen when using SSRIs and psychotherapy in conjunction with the stellate ganglion block, and also with the stellate ganglion block alone. And this is where we nerds break away from the class to talk about challenges and limitations to this study. We'll meet the rest of you back in the conclusion. The stellate ganglion, a nerve cluster near the cervical and thoracic vertebrae, appears to be related to PTSD symptoms that are rooted in the nervous system, which can be improved through locally anesthetizing the stellate ganglion. It is most effective in treating hyperarousal, avoidance, and other unregulated emotional behaviors. With greater symptom severity comes greater improvement, but overall, the procedure appears to be effective in men and women, military and civilian applications. Larger trials are underway to better explore the mechanisms of action underpinning these successes to make the non-invasive procedure even safer and more effective. However, it appears to be a promising treatment option, especially in conjunction with other therapies and when previous therapies have failed. With that, I'd like to briefly tell you about another paper that takes this story one step deeper and might blow your mind. Unless you're in the nerdy upper tiers, in which case, we've got a lot of detail left to cover. I hope you're ready. Let's talk about the connection between the stellate ganglion, PTSD, and chronic pain in a case study style. This research paper is called Stellate Ganglion Block for PTSD and Chronic Low Back Pain, a case report of 3 veterans. It's by Sterling, Fisher, and Wordbury from the Journal of Clinical Medicine, this time published way back in 2025. If this sounds like your experience with stress disorder and undiagnosable pain, I'm pretty sure you'll want to hear it. While SGBs have been used in PTSD applications, they've also been applied for chronic pain, including the head, neck, upper limbs, complex regional pain syndrome, chronic myofascial pain, and chronic lower back pain. The connection between all of these things being, the authors theorize that it's due to a shared problem underlying PTSD and ongoing chronic pain called central sensitization. This might explain why military personnel, in particular, are highly responsive to the stellate ganglion block. Central sensitization is caused by an elevated response to nociceptive pathways. Those are the sensory nerves responsible for detecting painful, dangerous, or potentially harmful stimulation events and relaying that information back to the brain, which presents as hyperalgesia, abnormally heightened pain sensitivity, and allodynia, perception of non-painful stimuli as painful or harmful. Central sensitization also has ties to the psychosomatic nightmare diagnosis of fibromyalgia. Underlying central sensitization and PTSD may be anxiety sensitivity. Anxiety sensitivity promotes avoidance of activities that may be painful or perceived as painful, which then may limit healthy self-support options, as well as life, resulting energetic drain and pain as a traumatic memory trigger may then worsen PTSD symptoms. And furthermore, neurostructural changes have been seen in both PTSD and chronic pain patients. On top of prefrontal and hippocampal diminishment, the old amygdala, the part of the brain that processes survival threats, is overstimulated in each case, indicating decision-making, memory, and fear responses may also be impaired. The immune system is also dysregulated, pumping out and over-uptaking pro-inflammatory signal transmitters, which are causes of additional pain and disorder. In other words, there are many reasons to study central sensitization, including the symptoms that we accept as PTSD. These connected conditions may be attenuated also by stellate ganglion blocks, as the stellate ganglion has connections to the hypothalamus, amygdala, and anti-inflammatory signal transductors. It could undo the damage and hyperactivity seen in the brain, correlated with chronic pain syndromes. And in this paper, for a change, we see 3 clinical case studies describing symptom, procedure, and results. I think you'll want to hear them. Case series. Patients were assessed for PTSD symptoms by a psychiatrist using the Clinical Administered PTSD Scale for DSM-5. CAPS-5 is a structured interview that makes a current diagnosis of PTSD as well as assesses PTSD symptoms over the past week. Standardized questions are used to target the duration and onset of symptoms, impact of symptoms on daily functioning, and change in symptoms. Pain levels were similarly assessed at visits and over the phone. Patient 1, 40-year-old female African American veteran suffering from non-responsive PTSD, migraines, chronic low back pain, neck and arm pain. Previous treatments included SSRIs, topiramate, psychotherapy, and trauma recovery programs. For pain, duloxetine, gabapentin, epidural steroid injections, radiofrequency ablation, and peripheral nerve stimulation. None of these treatments helped with the PTSD or pain symptoms in this patient. Within 1 day post SGB, her pain dropped to 0 out of 10 and PTSD symptoms disappeared. After some recurrence, she was retreated at week 8. 1 year later, she still had reduced PTSD symptoms and no upper limb pain. Patient 2, 55-year-old female Caucasian veteran, history of mental disorder, including bipolar, conversion, and post-traumatic stress disorder. Over 2 decades of chronic low back pain were also noted. Previous laminectomy, non-stimulatory anti-inflammatory drugs, duloxetine, methocarbamol, ibuprofen, topiramate, and epidural steroid injections were not effective in managing her conditions. After stellate ganglion block, her pain and mobility scores increased, and she reported lesser PTSD symptomology, all of which were still observed 7 months after the procedure. However, her lower back pain was not noticeably improved. And patient 3, 29-year-old female Caucasian veteran, severe PTSD, chronic low back pain, shoulder pain, and headaches. Previous treatments included physical therapy, medication, epidural steroid injections. Following the stellate ganglion block, headache and shoulder pain scores dropped from 10 out of 10 and 6 out of 10 to 1 out of 10 and 0 out of 10, respectively. Back and PTSD symptoms were not affected until 1 week later. She repeated the stellate ganglion block procedure and underwent sacral radiofrequency ablation to assist with the low back pain, which was more tolerable following the ganglion block. She continues to undergo SGB every 3 to 4 months to manage PTSD and pain symptoms. So, 3 women, ages 29 to 55, with mixed chronic pain and PTSD, both unresponsive to traditional treatments, underwent stellate ganglion block and had significant reductions in each category, sometimes after repeating the procedure, with chronic lower back pain appearing to be the least improved condition in one case. Headache, upper extremity, and PTSD symptoms greatly improved across the board. And from there, in Conclusion. It seems that central sensitization lies below both PTSD and complex regional pain syndrome, chronic pains. Under central sensitization, pain detection and interpretation become artificially heightened by the nervous system, potentially without injury, leading to poorly responsive traditional treatments. And with that, lastly, I highly recommend that you check out their figure, linking conditions like restless leg syndrome, joint disorder, chronic fatigue, GI issues, and pelvic pain to the other ailments that we discussed today through the shared factor of central sensitivity syndrome. Thank you, as always, for being here and learning with me. I hope this research has given you a new potential treatment option and new perspective on the overlap between chronic, unresponsive conditions. And I look forward to meeting up again soon as we keep exploring our complex, centrally sensitive biological systems, perhaps faster than Western medicine can. Hail yourself. Hail finding the answers that you need. Hail respite from chronic pain and discomfort. And I'll talk to you soon. Bye bye.